yoga, meditation, mindfulness-based stress reduction. Then the counseling and therapies are there. And ask the patient to go for the support groups. They should share their experience with the others facing the similar challenges can sometimes calm their anxiety. Medical therapy. It's a vast. It includes the ovulation-inducing agent. The clomiphene citrate is the most commonly used ovulation-inducing agent. It is the first line for inducing ovulation in PCO women. It blocks estrogen receptors in the hypothalamus and its dosing starts at 50 mg per day for 5 days. Monitoring required to adjust the dosage. And second induction agent is letrozole, which is the aromatase inhibitor, reducing the estrogen production. It may be more effective in certain populations, example obese. And this includes the multiple gestation and ovarian cyst formation. Then there are the insulin sensitizing agents, which are usually we attach with the ovulation induction for their better purpose. For example, metformin. It improves the insulin sensitivity, it restores the regular ovulation in PCO, and reduces the androgen level. So we combine this metformin with the ovulation inducing agent, as I am going to discuss the under. Now here is the dosage schedule and effect of the clomiphene citrate. The dose for normal women begins with 50 to 100 mg per day, and you usually start prescribing it at day 2 or day 3 of the menstrual cycle for the next 5 days till day 7 or day 8 as per your startup. And when you start with the 50 mg per day, you give a one cycle, and if the patient doesn't conceive, you increase the next cycle to 100, then to 150, and then to 200. However, no advantage has been seen in using the dose greater than 150 mg per day. So you can start with 100 mg and you reduce the treatment, and you can reduce the treatment time for the patient. 75% of pregnancy they occur in the first cycle, first 3 cycles, 80% will ovulate. 30 to 45% will get pregnant as seen in the most of the studies. However, there would be 20 to 25% will not respond at all. So when the person doesn't respond at all, you can shift the patient to other inducing agents like letroles. And you can also combine the metformin, as I already told you, with this confirmed citrate. With the letrozole, the regime starts from 2.5 mg per day from cycle day 3 to day 7. You can also give 5 mg per day from cycle day to day 7 at a fixed time each and every day. You can also combine letrozole with the, as I told you, with the metformin. The metformin doses would be like 500 mg per day for the first cycle, and then you can increase the dose of metformin the first week, after the first 2 weeks, to 1000 mg per day as the patient responds. Now here is the graph. This shows how you go with the letrozole and concentrate. Suppose the patient starts with the menses that is counted as day 1. Then you add letrozole of 2.5 to 7.5 mg that you have already decided that you want to go with on day 3 until day 8. 3, 4, 5, 6, 7, 8. Then you go for the ultrasound monitoring. You monitor basically the follicle size here and the endometrial thickness. On and around day 12 to 14, if you found that the follicle is around 18 mm, 18 to 20 mm in size, and the endometrium thickness is good around 7 mm, I find 5, 6 to 8 mm is good enough. Then you can go for the HCG trigger that we call the injection that will give rise to ovulation. You can start with 5,000. If the patient doesn't ovulate, you can increase to 10,000 HCG as shown in this figure. And then you ask the patient to stay with the husband for the next 1 week, alternate day or maybe daily. And then after 14 days of giving the trigger, you verify the pregnancy by either UPT kit or by beta HCG, that is serum beta HCG, as choice is yours. In the second graph that we see in this option B, here we are combining letrozole that is start 2.5 to 7.5 mg per day from day 3 to day 8, and we are adding here the FSH. This is the follicular stimulating hormone. We are adding here because if somehow the patient is not responding well to single letrozole, if there are some other poor ovarian reserve, the patient is not ovulating or you're not getting even a single egg, then you can add FSH from day 5. And then you see the size of this follicle. If it's again it's lesser on the size is not your optimum level, then you can add the FSH again alternate days, like day 5, day 7, and then day 9. And then again you check the size by US monitoring, that is ultrasound monitoring. If you get the optimum follicle size around day 14 of 18 mm to 20 mm, you again put the FSH trigger here, and you ask the patient to stay with her husband, or you can even go for intrauterine insemination, that is IUI, and then you verify the pregnancy after 14 days of triggering. In this, the last option we see, we are using the GnRH antagonist here, along with the FSH. If the patient is having a kind of this anovulatory thing with that premature LS surge is happening, and the follicles are 14 mm and the LS surge is there and the patient ovulates, then it disrupts the whole cycle. To prevent the premature LS surge that we call it premature ovulation, We add the gonadotropin releasing hormone antagonist here at around day 7 to day 9 daily. And then we give the trigger at 10,000 IU when the follicle size is around 18 to 20 mm. And then you can go for basically this type of thing we use in the IVF. Then after the giving the trigger, 36 later onward, we ask the patient to come up with the oocyte retrieval, and then we did the embryo transfer. So here are the तीन protocols that we are using. One is for the normal pregnancy, we are not using IUI. The B is for the IUI. The C when we go for the IVF. And as I told you, gonadotropin is the FSH, and this is called human menopausal gonadotropin HMG. Basically, HMG is a combination of FSH and LH. And FSH stands for pure follicle stimulating hormone. I mean, it just has FSH and a bit of LH. Administration, we can give the daily supplement injection of the FSH or HMG. Indication when the other regions are ineffective in producing the ova of your child. And control ovarian hyperstimulation for IVF, you want multiple follicles as we require in IVF, then you have to go for FSH and HMG injection because that can't be attained with the letrozole and clomiphene citrate. You have to take these hormones. Monitoring requires the same frequent ultrasound and estrogen levels to prevent the OHSS. Now, what is the OHSS? It's ovarian hyperstimulation syndrome that we learn in the subsequent slide. And the risk is higher chance of multiple pregnancies and OHSS, as I already told you. Now here is the one again the thing to show that how to go with the FSH and HMG induction. On day 2 of the menses, you are giving clomiphene citrate of 100 mg, or maybe you can go to 150 mg per day for the next 5 days. Then on day 7, if you didn't find a good ovum or didn't grow, no better growth of follicle, you add the FSH and HMG as I told you 8, 9, 10, 11, and 12 day of menses along with the ultrasound monitoring. And if you get the good follicle on around day 14 of around 18 to 20 mm, you give the FCG trigger 5,000 and 10,000, whichever patients ovulate with. And after the results of this trigger, you can go for ask the patient to stay with the husband, or you can go for IUI. And if you are planning for IVF, if you get a multiple follicle, then you can even plan the oocyte retrieval and embryo transfer later on, depending on the number of follicles that you obtain. Here again the cycle which is showing you how to estimate the ovaries. Here day 1 to day 5 we are just doing the baseline ultrasound to see the follicle growth. And on day 3 we are adding the gonadotropin. It could be FSH and it could be HMG, whatever you opt for. Then you go for ultrasound to maintain the follicle size. And then on day 9 if you get the good follicle size like 14 mm or the 18 to 20 mm, then you can inject the FCT trigger here. After 3 6 hours of triggering, you will get the oocytes and you can breed them. And then you can take them for fertilization by ICSI, or you can go for embryo transfer, and then this is how it goes. After embryo transfer, however, you have to support the uterus by the usual phase support to give progesterone and estrogen tablets both. You can even add the progesterone injections, you can either add the estrogen injections or estrogen tablets as per the patient's demand. Now, here are some surgical treatments that I'm going to discuss for the fertility thing only. Laparoscopic surgery for endometriosis and fibroids. Endometriosis surgery it includes the excision or ablation of endometrial implants, restoration of normal pelvic anatomy. When fibroid removal happens, it's called myomectomy to preserve the uterus, and it can be performed stereoscopically, laparoscopically, depending on the location of the fibroid. Consideration here the risk for vaginal formation later onward, and there could be potential for uterine rupture in future pregnancies if you have done the multiple myomectomy. You can even perform the tubal surgery for blocked fallopian tube. Procedures include salpingostomy, opening the blocked end of fallopian tube, and pyeloplasty reconstruction of symphysia. Success rate depends on the extent of damage, and adult pregnancy risk remains if you treat any kind of tube. And here comes the assistive reproductive technology that I already discussed with you, that we have a certain protocol for the ART, for the IVF, and the one thing here is intrauterine insemination. It's called IU1. It means the sperm is collected from the husband, it washed and concentrated, and it's timed with ovulation, sometimes combined with ovulation induction drug. Success rate approximately 10 to 20% per cycle, and it is then by the age, infertility cause, and sperm quality. Now comes the in vitro fertilization, where we stimulate the ovary using the gonadotropins to produce multiple follicles, as I already told you with the help of the graph. Then we go for the egg retrieval by the transvaginal ultrasound cardio aspiration. Then you fertilize the egg by mixing with the sperm in the lab. We grow the embryo. We monitor the embryo for several days. I won't say for several, but for day 0, day 5, and then we freeze them, or we just transfer them. And this is called embryo transfer, which means the placing embryos into the uterus. Now, embryo transfer could be day 3 ET, as you must have heard, or day 5 ET. Day 3 ET means we are transferring the day 3 embryos. Day 5 means we are placing the day 5 embryos. And then the embryo transfer could be fresh and frozen. The fresh embryo transfer means you are placing the embryo in the same cycle, and frozen embryo transfer means we are placing the embryos in the next cycle, or maybe later onwards, but not in the same cycle of ovulation induction. Success rates vary by age, higher in women under 25, and concentration includes emotional, financial, and physical demand. Now here is intracytoplasmic sperm injection, which is called ICSI. Indications: severe male factor infertility, low sperm count and motility, or previous IVF failure. Whenever the patient is having a very low sperm count that you can't do IVF with that, then you can just pick a single sperm, which is good in morphology, good in the functionality, and you just inject that simple single sperm into the egg, which is called ICSI, under the microscopic view, no doubt. Outcomes of similar pregnancy rates to conventional IVF. So it gives you a hope if you are having a very less sperm count. Then there comes the pre-implantation genetic testing, which is called PGT. The types are PGT-A. When you do the antibody screening for chromosomal abnormalities, PGT-M. When you study the monogenic single gene defect, and PGT-SR, structural rearrangement when you study these things. The process includes biopsy of embryos at the blastocyst stage. You just take out one cell and you study all these things. Genetic analysis, it means that we are doing the genetic analysis before the embryo transfer. What is the benefit of this thing? It reduces the risk of genetic disease, and plus it improves the implantation rate because we are transferring the best embryo, and it reduces the miscarriage. Now there is third party reproduction, as you might have known, egg donation and surrogacy. Egg donation means the woman with POI, poor ovarian reserve, or genetic concern, when they don't have ova in their ovary, you can take the egg donor. Egg donor has to be anonymous, or it could be a known donor, and we screen the donor for the infectious diseases and all the genetic condition that is prevail. The process includes the donor undergoes the ovarian stimulation, as I already told you, by basic agent, mostly the hormones, because here you want multiple eggs. So you don't use clomiphene and lateral here. You use for HMG or FSH for the stimulation. And, 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 and then you go for egg retrieval. When you retrieve the egg, then you mix the egg with the this thing, sperm of the patient's husband, and then form the embryo. And the recipient uterus is then prepared with the help of estrogen and progesterone tablets, or estrogen progesterone. You can even use the estrogen tablets and progesterone injections. And then when the uterus is ready, your ova or your embryo is ready to do the transfer. The success is higher because we are using the eggs here from the younger woman. Surrogacy is also a third party reproduction. It means gestation surrogacy. Surrogate carries the pregnancy not genetically related to her. And traditional surrogacy, where the surrogacy used her own egg. Indications: where there is absence of uterus in the patient, when there is severe uterine anomalies, and medical condition which contraindicates the pregnancy. So here a patient can offer surrogate mother. Emergent treatments are ovarian rejuvenation. Techniques include platelet-rich plasma. Here, the platelet-rich plasma is injected into the ovaries to stimulate the follicular development. And now there is a stem cell therapy. The research are ongoing into restoring the ovarian function by using the stem cell. However, it is still experimental, but it may offer an option for the women with POI or diminished ovarian reserve. Then there is uterine transplantation. Procedure includes the surgical transplantation of the uterus from a donor. Candidates are infertile women with uterine factor infertility. The challenges are there for the immunosuppression and active concentration regarding the donor and recipient. So it's under trial. Now the complication of infertility treatment. That I already discussing you in the previous slide, OHSS, that stands for ovarian hyperstimulation syndrome. Incidence occurs in 1 to 5% of women undergoing ovarian stimulation. The risk factors are young age, PCO, and high estrogen level. Now, what is the estrogen level? When you find an estrogen level just before the ovulation, or you can say that day 12 of your menses, around 3500 picogram per ml, it means the patient is going, patient can lead to OHSS. So here, what we usually do, I'll let you know further. Let's just come to the classification. It could be of three types: mild, moderate, and severe. In the mild, the patient complains of abdominal discomfort, abdominal pain, slight ovarian enlargement. The patient complains of headaches or vomiting. In a moderate, all the mild OHS syndrome plus the patient complaint of ascites, there could be pleural effusion, the severe nausea, vomiting, bloating, and the severe the patient complains of loss of headache, severe ascites, pleural effusion, discomfort in the breathing, and the cause could be the thromboembolism, renal failure, significant ascites. How you prevent it? We use the lowest effective gonadotropin dose when you do the stimulation of ovary. You can say the control ovarian stimulation is the word nowadays we use, or you can do the coasting. Coasting is withholding the gonadotropin when estradiol level is high. Suppose on day 12 you measure the E2 level, and it comes around 3,500 picogram. Then you don't stimulate the ovary further. You withhold the gonadotropin, FSH or HMG that you were giving, and you just stop. You just avoid the trigger. You won't give the this SCG trigger 5,000, 10,000 till you get the sugar level under your limit. I mean, when it decreases, then only you can go the SCG trigger. This is called posting. And secondly, you can also do that you trigger the ovulation with the GnRH agonist rather than giving with the HCG, because HCG causes the more of the fluid shift from the ovary to the tissues. So you can just withhold that one. And secondly, you can even cancel the cycle. So this is the prevention of doing this. And management would be if a person has land into VHS, the management would be supportive care, monitoring the patient and hospitalization if severe, and giving the patient IV fluid to restore the blood, you can restore the plasma. If a patient is having a thromboembolism, you can give the heparin, enoxaparin. If the patient is having a renal failure sort of thing, then you can give the patient a dialysis. If there is significant ascites, you can tap the ascites. If there is fusion, you can tap the fusion. And then you can give the patient anti-massive and antibiotics. Whatever the patient asks for, you give the patient this kind of management. The best is you try to avoid the OHS. However, 1 to 5% of patients can lead to OHS despite all the precautions. Multiple pregnancy is again a complication of this IVF, which is increased with the ovulation induction and ART, because here in the ART we are using the gonadotropin, which leads to the multiple follicle formation. The risk to mother is there is gestational diabetes because of multiple pregnancy, hypertension and preeclampsia. Risk to fetus will be the preterm birth, low birth weight and developmental problem. Prevention would be you carefully monitor during the ovulation induction and you better transfer the single embryo. However, in India we usually go for 2 or 3 transfers. Emotional and psychological impact is too much in this IVF thing. The stresses are treatment failures, hormonal fluctuation, and financial burden, how to mention. The psychological effects are anxiety, depression, decreased self-esteem. Support strategy will include the psychological counseling, stress management techniques, and open communication with the partner and healthcare provider. Now, there are ethical and legal considerations in infertility. Ethical issues in ART is embryo freezing. Decision regarding unused embryos. You have to take the consent for the from both the parents what to do with the unused embryos, how to dispose them, or you can use them for some other one. So consent there should be for the use, donation, or disposal. Then there is surrogacy. So there is a concern about exploitation, especially in the low-income population. The rights of the surrogate versus the intended parent has to be laid out. Then there is a concern regarding the genetic modification. So ethical debates is still going around the gene editing. Legal aspect of donor gametes and surrogacy are also there, and it varies widely between the countries and states. Some regions they have strict laws governing ART practices. In our India, this year we have also been given this ART guidelines. Legal parenthood may require court order for adoption proceedings. Policies on donor anonymity and the right of the option to know their genetic origins has to be discussed. Rights of the infertile couple and the child. Ethical discussion about who should have access to ART is the most important thing. Discrimination concerning age, marital status, sexual orientation. The best interest of the child has to be kept, ensuring the child welfare is paramount. They are the consideration of the parental preparedness and support system. Now, psychosocial impact of fertility. There is a lots of emotional and psychological effects on couples. The individual can feel of inadequacy, isolation, and grief. There could be a strain due to the reducing coping mechanisms and sexual intimacy may decrease. Cultural and social pressure is also there in our country, like stigma associated with childlessness and family expectations can add more stress to the couple. So we should provide the counseling and support options like fertility counseling, psychological therapies, and support networks like online forums, local support groups, and sharing experiences which can reduce the feeling of isolation. Now, what are the advances in infertility research? Genetic and epigenetic research in infertility. Genetic insights stand for identification of genes involved in oocyte development and implantation. Epigenetics stand for study of heritable changes in gene expression without altering DNA sequence and mindful factors that influence the fertility through epigenetic mechanisms. Applications, potential for personalized medicine approaches and development of targeted therapy. And there are also the innovations in fertility preservation, especially for the cancer patients. We can go for suicide and embryo preservation before we start the gonadotropin treatment. Ovarian tissue freezes are being done nowadays which allow for potential restoration of ovarian functions later on birth, and it has resulted in successful pregnancy. Or we can use the protective agents when we are using the chemotherapy to reduce the ovarian damage, like GnRH analogs. Now, what are the future directions in ART? The first is the artificial gamete, generating the sperm from inside from its stem cells. During the trial, it could offer a solution for individuals who are lacking the viable gamete. Then they don't have to go for a donor. Gene editing, potential to correct the genetic defect causing infertility. However, the ethical considerations are significant here. Now there is an improved culture system for the development of embryo in vitro, non-invasive embryo assessment, metabolics, and time-based imaging to select the best embryo. And the last is artificial intelligence to add on. To decide the algorithms to predict the treatment outcomes and to have the personalized protocols to improve the success rate. So let me conclude that female infertility is a complex condition with multifactorial causes. A thorough understanding of the underlying anatomy, physiology, and potential consequences is essential for effective diagnosis and management. Advance in medical technology and research continue to improve the prospects for individuals and couples facing infertility. Holistic care, including medical treatment, psychological support, and ethical consideration, is vital to address the multifaceted challenges associated with